So without further ado, I'm going to hand over to Professor Decker, who's going to talk about key issues, is going to talk about post-colonoscopy colorectal cancer, my favorite topic in fast-growing cancer or poor colonoscopy.
I know it's your favorite topic, so it's more challenging for me, this task. So indeed, the question I was asked is whether post-colonoscopy colorectal cancers are due to fast-growing cancers, which is a likelihood that we as endoscopists like to bring forward, or does it have to do with quality of the colonoscopy? And indeed, my learning objectives, I think they're a bit repetitive of what Roland just said. What is the definition for PCCRC and what are the causes? That's more specific. Which genetic syndromes are prone for PCCRC and how can we recognize these syndromes to improve surveillance and outcomes? So you might be aware of the statement that was produced by the WEO CRC Screening Committee on post-colonoscopy colorectal cancers. And we were part of it. I think this was really a great step forward in trying to understand what's happening in those patients that suffer from cancer, although they underwent a preventive endoscopy, and also trying to have that as a basis to try to, of course, prevent those. And looking at the definition, the PCCRC is a cancer occurring after a colonoscopy in which not a cancer was detected. And we take a 6 months time before really looking at those cancers, because within the 6 months, it might have to do with not having taken biopsies, but going to operation or some other reasons. So 6 months until later. And then there's two real different types. There's the interval type, which is detected even before the recommended surveillance or maybe screening interval. And there's also the non-interval type, which is detected at or after the recommended moment. And amongst all of that, of course, again, there's also higher up the possibility of just having a cancer that would never have been able to see because it developed so quickly within the advised period of surveillance. And looking at the meta-analysis, regrettably, post-colonoscopy cancers do occur.
And you'll see that in some of the subsequent slides. Just to highlight that it's probably more common than we think. And if you are a high volume screening colonoscopist, chances are you've come across a few of these lesions. We talk about a usual adenoma dwell time to colorectal cancer of about 10 to 15 years, but for Lynch syndrome, that's dramatically reduced. So we often find, and I've actually had 2 patients referred to me in the last month, and I've scoped both of them, and they both had these small little polyps with cancer in it, and the polyps were probably just in the region of 15 millimeters, one in the cecum and one in the rectum. So just to highlight that just because you see a small polyp doesn't mean you should switch off and not go through your basics, look at the blink features, look for demarcated areas, because these patients often have these small polyps which harbor malignancy. So on the right hand side you can see one of these patients, and that was a lesion in the rectum, a malignant lesion, which I ended up doing an intermuscular dissection for to resect. So surveillance colonoscopy does help in these patients, and I'll show you some of the data. It does reduce colorectal incidence and associated mortality. But the big issue with these patients are interval cancers, and whether this is probably metachronous lesions. And I think Professor Decker highlighted some of the issues with regards to interval cancer. Then just remember other sites of cancer, so urothelial cancer, and only the US Multi-Society Task Force advocates for doing urine cytology for these patients. And then don't forget the pancreas, the prostate, skin, so there's other malignancies that we need to look for as well. So I think there is a bit of uniformity, and you'll see that many different countries have different surveillance protocols, and most of them differ or range between 1 to 3 years. Most of the societies have settled on 2 years, and I'll show you some of the data that supports this. And I think it's well documented that the different genetic varieties confer different risks. So screening should start at the age of 25 for high risk variants, and for slightly lower risk variants at the age of 35. So does surveillance make a difference in these patients? And it does. Number one, it does reduce the proportion of colorectal cancer. But even if you do have colorectal cancer in these patients, you still have a mortality benefit, and that's going to owe to picking up earlier disease. So I think this is the big issue with these patients, and a lot of them have metachronous lesions, and a lot of them have interval cancers. And what you can see in both of these studies is that the duration or the time period to developing an interval lesion is actually quite short. So you can see a mean or around 50% median duration of about 24 months. And you can see that in both of these studies highlighted here. So about 50% of interval lesions developed at around 24 months. But of course, this does vary with the mutation, with the genetic variant and other factors as well. So I think Professor Decker already highlighted this, and I completely agree with the sentiments. So how do we overcome this interval period or these interval cancers? Should we shorten our surveillance intervals? Should we base this on mutations? Is it because of non-polypoid growth, or is it because of colonoscopy quality? And I completely agree with her that the last point is probably the most relevant point and is the one for discussion, and is what we should focus our attention on. So this is a study done on a registry in Germany, the Netherlands, and Finland. And you can see that they have varying surveillance intervals between 1 and 3 years. But basically, it shows that there is no difference in colorectal risk or tumor stage with shorter intervals. So again, reason or backing for the societies to say that 2-year intervals are probably adequate, and I agree with Professor Decker there again. But they have highlighted some risk factors, and perhaps we could use these risk factors to further or individualize surveillance intervals in patients. Based on this, the ESG does recommend surveying patients every 2 years. But again, this has been highlighted. If you have an incomplete colonoscopy, if you have poor bowel preparation, do not wait for the next interval. But patients should be scoped within 3 months